your name, raise your name.
Give me 1 second.
Oh, he's got it. You moved your handouts back there. Did you see him go behind the mirror? I mean, behind the curtain? No? He disappeared. I'm just going to start. You know, the guy's not here, but the guy that's skating, he just ran away. He went behind there, but he doesn't have any sound. No, what? Don't start. Well, we should do something fun if we're not going to start. I know, we might do a song. People want to do a song. Wait a minute, there's the dog. Somebody in the back row ask him what his name is.
My name's Davis.
Davis.
Yes.
Okay, it's good to know.
Are we good to go?
Yeah.
Okay, are we good to go?
We are.
Okay, we're going to go. So, thank you everybody for attending this institute. We're really excited about the number of people that signed up for this. We are calling this a paradigm shift for treatment and research in sensory processing disorder. We hope to introduce you to a lot of new ideas and we have a couple of breakout sessions today. In fact, I'll tell you the schedule first, and then I'll introduce the people here that are standing. So just so you have an idea, we have 6 different speakers today who are speaking at different times, but there'll be a break at 2:30 and a break at 5:50. The break will be combined with a working group. So you'll have a work group to work on a few questions during the breakout group discussion. And at the end, we'll have questions and answers. So I want to take a minute to introduce all of us. I'm Lucy Jane Miller. You probably figured that out. I am the founder and clinical director of the STAR Center in Denver and the research director of the SPD Foundation, also near Denver, and associate clinical professor of pediatrics at the University of Colorado, author of a couple of books, and 9 norm reference standardized assessments. Our newest assessment is called Sensory Processing 3 Dimensions. Hasn't been standardized yet, but WPS is going to be standardizing it. I'm doing it with Dr. Sarah Schoen and Dr. Shelley Mulligan. So the 3 of us are working on that test. It should be available this end of this year maybe, or by AOTA, I hope next year, but you never know how long things are going to take. So this has been a wonderful collaboration of many people putting this talk together. Karen Butendog is the Director of Occupational Therapy at the STAR Center. She joins us from South Africa and now lives in Colorado where she directs the OT department. Dr. Stephen Camerata, if you want to guess which one he is, not here yet, but he will be here. He's at Vanderbilt. He's our colleague that's helping us with the multiple baseline research, which we will be doing a mentorship on this summer in Colorado and a talk on today. Dr. Stephanie Capshaw. Stephanie is a clinical professor of OT at the University of Texas at El Paso. And she was an OT at the STAR Center and the Sensory Processing Disorder Foundation for a year, and now she's back in Texas, which we're really sad about, but we're so glad she could join us today. Lisa Porter, almost Dr. Lisa Porter. She's finishing up her degree at Rocky Mountain University of Health Professions. She'll have a PhD, and she directs Sensory Kids, which is in Portland, Oregon. Lisa is our faculty member for Mentorship 2, and does a lot of training with the foundation. A clinical advisor to the STAR Center, and associate director of research at the SPD Foundation, associate professor at Rocky Mountain University, and a clinical instructor at the University of Colorado. So all together we will be presenting this today from now until 6:30. 2 breaks. Okay, thank you so much. So an outline of this presentation
Really big. There are obviously many other excellent facilities throughout the world. Actually, I just got back from Dubai and Abu Dhabi, which was amazing. It was an amazing experience to lecture to a group of people who you couldn't see anything but their eyes. So that was really an interesting thing. Dubai has been built in the last 5 years. It's all built on sand. Huge buildings, just amazing, but I know you're not here to hear about that. STAR treats kids who are children. We actually have a new program, which is our baby program, which is kids who have hard births. They're at-risk births. We also see preschoolers, teens, and adults with developmental, behavioral, and learning challenges. This is a picture of where kids come from all over the United States to see us. 40% of the kids who come to us come from outside of Colorado, and 15% come from outside the United States. So we draw people from a lot of different locations. We are really passionate about our research projects, which we've been doing for 40 years, and we run mentorships every month for a week, intensive mentorships, and we've trained over 400 professionals. If you have been a mentee in our program, would you stand up if you're here and you have been a mentee? So thank you very much for coming. It's been great to have all these people who have been trained in our model. If I asked all of you to write down a definition of sensory processing disorder, we probably have 100 different definitions of SPD. This is our simple definition: difficulty responding appropriately to sensory input. They have atypical motor, emotion, attention, or adaptive responses after sensory stimulation. So what makes it SPD is not a sensory symptom, but a sensory input, because what comes out is usually not sensory, it's behavior. Sometimes motor behavior, but almost always behavior. And it's only considered a disorder when it causes significant difficulties with daily routines and tasks. So if you're a little sensitive to tags, but you're an OT and you're working like a normal OT in a regular job, you've compensated for your disorder. It's not a disorder if it doesn't cause you daily problems. So you have to have a fairly significant degree of difficulty for it to be considered a disorder. Otherwise, you might just say it's sensitivity. Autism spectrum disorder often gets mixed up with SPD. And one of the great things that happened, I think, because of our advocating for SPD to get into the DSM, is that we did get it in under autism. So autism now includes what you see in blue up here on the slide: hyper or hyporeactivity to sensory input of unusual interest or unusual interest in sensory aspects of the environment. And it has these exact examples. So we feel really excited that the DSM now does include at least a mention of sensory processing, although SPD didn't get in by itself. What we heard just recently was that the committee that we submitted it to actually approved it and sent it up to the editors with an indication that it should be approved and included, but the editors turned it down. So even though the committee had agreed that it should be put in, the editors turned it down. I'm not a political person, and I haven't been involved in the politics of the DSM. We worked only on the science, and we worked really hard, and we have lots and lots of research. But we didn't have the political connections, and I think that was part of the problem. Of course, you know SPD affects one or more sensory systems, and you know that there are 8 sensory systems. Used to be 5, then it turned into 7 when AIRS was working and added vestibular and proprioceptive, and we now always talk about interoception when we teach. Interoception is a sensation that originates within the body. Hunger, thirst, breathlessness, pain, temperature, anything that you can feel in an organ is interoception. And so many of our kids have gut problems and other problems that we now include that. Interoception is linked with how you process emotion. And there's a lot of variability in how well people perceive their interoceptive signals. And a lot of research that shows that those who can feel their heartbeat are more intuitive, more empathetic, have stronger emotions, are better able to control negative emotions. So when we work with children, very often we start with having them feel their bodies, feel their heart rate, feel their breath. And that is the beginning of part of what we do for those kids. Oh, I forgot to say this. Anybody with one of these in your purse? Could you take it out? Now let's see how long it takes everybody to turn off their ring so that it's quiet and we don't get interrupted by cell phone signals. I don't know what reminded me of that. Anyway, we would really appreciate if you turn your phones to quiet. In 2007, we published an nosology, which is a classification scheme that looks at the subtypes of SPD. We are not going to go over this today, except just to remind you that we are working from a frame of reference that includes sensory modulation disorder, sensory-based motor disorder, and sensory discrimination disorder. And, whoa, those little kids are supposed to go around in a circle. What is the so what of sensory-based treatment or sensory integration therapy? It's so important to keep in mind that the so what of treatment is joie de vivre, joy in life. Quality of life issues like social participation, self-regulation, and self-esteem are the reason we do treatment. We don't do treatment because we want to repair somebody's nystagmus or fix their touch sensitivity. We do it because of the things that happen because of those things. And it's so important to remember these so what issues. Whenever you're talking about a paradigm shift, you have to talk about a theory of change. What is a theory of change that we are thinking about with our kids? Part of it is that in the past there's been a reliance on factor analysis as a way of grouping the kids who have problems. And there's nothing wrong with factor analysis. Anybody who develops tests does factor analysis. But factor analysis tells you information about a test and how things group, how test items group on a test. Ayres factor analyses were pretty clear, as well as Shelley Mulligan's study of 10,000 children, that the factors on the SIPT were things like somatodyspraxia, somatosensory deficits, bilateral integration and sequencing, visual perception, visual motor coordination, and generalized sensory integration dysfunction, depending on which factor analysis that she did you were looking at. Those were all wonderful research projects, but they only were looking at one test. When we have done our theory of change, what we've done it on is based on a cluster analysis, which looks at many tests, not just one test. So we look at the relationship between sensory modulation disorder, sensory-based motor disorder, and sensory discrimination disorder, and how those things go together or apart, which will help us figure out a new paradigm to look at sensory processing from. I've included just a little bit of data here for those of you who are data junkies, which might be one person in the audience. But if you want to know more about our cluster analysis, I'd be happy to talk to you at the break. We've looked at how each of the OR, UR, and sensory craving clusters go together with posture, praxis, and discrimination disorders, and it's very interesting. We have a theory of change that the changes that we see in treatment from sensory integration, or we call it occupational therapy, are due to neuroplasticity. The brain adapts to environmental challenges. Processing and integrating sensory information improves the child's function and occurs during treatment. Enriched environments can cause changes in neural activity. And our theory of change is based on work from Porges, Panksepp, Kessley, Dan Siegel, Greenspan, and Weider. So, and Ayres too. Ayres I know all of you know about, so I'm not really going to be talking about her too much. But we believe that the change is due to maintained regulation, empathy and concern for others, quality of relationship and attachment, and robust interpersonal processes. So these form the foundation of our treatment model. Sensory integration stimuli provides the best practice, a means to an end. It enables us to change the child if the focus is on the process and not the activity. We have seen many of our mentees come to us and they are focused on the activities. They're focused on going down the scooter board ramp or going on the big ball or spinning in a net or whatever it is. And they're not focused on the so what. They're not focused on the why we're doing these activities. So our process of change is to focus on regulation first, relationships second, and sensory processing as a means to an end. The change is caused by play-based experiences and intense relationships. So I brought a few books which I'll be sharing with you at my next part of my talk. Panksepp, Siegel, Rady, and others who have really tried to put together the theory of what neuroplasticity is, how we know it's happening, how does it relate to animal models, and so on. Our heritage, of course, is the work of Dr. Jean Ayres, who all of you know, and I'm sure you've read her book. So here's just a little tape of her so we can remember the great contributions that she made.
Before we can learn to read, write, and calculate in an academic situation, we must be able to attach meaning to that which we see and hear, be able to motor plan, and be able to organize our behavior well enough to participate in a classroom situation. There's a hockey ball. Down there. You gotta lie down there too. That's all I can do, David.
Hi.
Get the corners. Okay, what do we do first? That's right.
I love this little clip because it shows the three amazing things about her. First of all, she was an amazing scholar. If you haven't reread her blue book in the last year, please go back and read it. It's incredible that we now have the tools like fMRI to look at the things that she postulated were true and to show in fact they are what's happening in the brain. Number two, she's down on the floor at age 62 on a scooter board, eye to eye with kids. She was all about relationships. She really was. She didn't write about it, but she herself as a clinician was all about her relationships with the children. And number three, function, folding the blanket, which is a functional task. And that is what we'll remember her for, that and many aspects of treatment that she helped us learn about. So we have a 1 hour tape of Dr. Ayres that was made from the tapes I took of her in 1982, which is on our e-learning channel on SPD University. So if you want to see more of this tape, you can go there to see it. So that's the end of the introduction, and I think Sarah is next up, and I will be back later to talk about treatment. So thank you very much for your attention.
All right, just. Okay, dokie. Let's get something on the screen.
I wanted to ask, how many of you are OTs? And how many of you are COTAs? How many of you are from the East? And how many of you are from the South? And from the North? And from the West? West, yeah. And how many of you don't know where you're from? Did you get it up?
Yes,
Okay.
you're a good transition person. Okay, so I'm going to talk about our first paradigm shift for this morning. Is my voice too loud? Okay, everybody can hear? Okay, excellent. which is our supposition that SPD is real, which we're going to explore through a very brief and rather quick overview of only a portion of the relevant research to answer this question. We're going to start with evidence that SPD in relationship to other clinical disorders, and then go into some of the biological and behavioral evidence that SPD is unique and does exist independent of other disorders. So relative to the taxonomy, we know that these are not discrete symptom clusters, as Lucy just showed you, and in fact our research shows that there is a significant overlap among the subtypes. But where does SPD fit in? And this is kind of a joke because we've been exploring this question for 30 years or more to figure out how SPD fits in with other childhood disorders. So one way it could fit in is that there are two different disorders and there's an overlap. So some children have both conditions and some children have just one or the other. Another way to think about it is maybe they're completely distinct. Is SPD completely independent of all other clinical disorders? Or is it subsumed under another diagnostic category, or is another diagnostic category subsumed under SPD? And lastly, are they indeed just one and the same? So let's look at ADHD first in relationship to SPD. And one thing we know, which is from one sample and one study, is that there are a subgroup of children who have ADHD symptoms and also have sensory symptoms. And when you can see that here in the yes and yes category. So the number 74 shows us the number of kids in this sample who had both sensory and attention problems. But we also see from this sample that there's a group of children with ADHD who just have attention symptoms, and that's the number 57. And then there's a group that just has sensory symptoms, that's the number 50. So we can look at this depiction as one of the pictures we just saw filled in with a 40% overlap between ADHD and SPD, but then still 28% of that group has only SPD. And in fact, we can also differentiate these two groups physiologically. Some of you may be familiar with the research we did on the sensory challenge protocol, where the children came into the lab and they received a sensory stimulus over 8 trials, and this was covering about 5 different sensory domains. So what you're seeing here on the graph is a summary from trial 1 to trial 8. So if you look at the bottom line, that's the typically developing children. And what you see is the slope of that line goes down because the children habituate or get used to that stimulus after 8 trials. They're not reacting. But if you look at the 2 other lines, the top line is SPD and the middle line is ADHD, the first response to that stimulus is extremely high. But then the 2 groups are differentiated from one another in that the ADHD group starts to go towards habituation, looks more similar to the line of the typically developing children, whereas the SPD children are still reacting to that sensory stimulus after repeated trials. So habituation seems to be one characteristic that differentiates these 2 groups. And in a very small pilot follow-up study, we found that there was another dimension that might differentiate these 2 groups, which is called response inhibition, which is basically a task that requires impulse control. So, of course, that makes perfect sense, right? You would expect that children who have ADHD are going to have trouble with impulse control. And in fact, they had more trouble than the children with SPD. So it seems like this may be characteristics that help us differentiate the children who have ADHD without sensory symptoms from those who have just the sensory impairments. So what about autism? What is the relationship between SPD and autism? We do obviously know that a large majority of children and adults with autism have impairments in sensory processing. Well, in one study we conducted, we looked at parent-reported sensory symptoms in autism versus autism versus SPD compared to typicals. And if you look at this graph, the large bar in blue, or the middle bar if you don't have color slides, reflects the amount of sensory symptoms in the autism group. So is it possible that what contributes to differentiating autism from sensory processing disorder is in fact the amount and severity of the sensory symptoms? Another differentiator may be along the lines of what's called the empathy and systematizing theory that was developed by Dr. Simon Baron-Cohen in the UK. In his theory, children with autism tend to have lower empathy, but they're higher in this dimension of systemizing, which is the drive to analyze and explore and construct systems. So the systemizer likes to figure out how things work or sort things into specific categories. And not surprisingly, in this one study, what we found was comparing the group of children with SPD to the children with autism. The SPD group had more empathy, but the autism group had more systemizing behavior. So maybe another important dimension to look at. And then, of course, we can also differentiate these groups physiologically. This is data from, again, the Sensory Challenge Protocol. You're looking at it a little differently. So here we're just looking at the response to the first sensory domain. So you're seeing at the bottom of this graph the label of all of the sensory domains that we tested. And that first initial response, remember you saw, was really high in the children with SPD. So indeed, that seems to be consistent and a finding that might help us differentiate the children with autism from the children with SPD. So that middle bar is the group with sensory modulation disorder, and those kids had a higher response to the first stimulus delivery as compared to both the typical group and the group with autism. So the first bar, I know it's not in color on your graph, is the typicals, and the third bar are the children with autism. Additionally, we also can differentiate these groups by looking at their baseline arousal. So in this protocol, the children have the first 3 minutes sitting without any sensory experience at all to look at what their arousal is without any stimulation. And the autism group, which is the lowest line, the first line you see at the bottom, I know you don't have it in color, that's the children with autism. And then the other two lines, the middle line is the typical group and the sensory modulation group. Okay? So we think that this may be a better depiction of the relationship between autism and SPD. So while we know SPD coexists with ADHD and with autism, how might it be distinct? That is, what is the evidence that SPD exists as a separate disorder? So we'll first talk about some of the biological evidence and then look at some of the behavioral evidence. Some of the most important and groundbreaking work that's come out in the last 2 years in establishing a biological basis for SPD comes out of the work of Dr. Elisa Marco at the University of California in San Francisco and her lab. She and her colleagues are using another form of MRI called diffusion tensor imaging. And she's compared her data between children with SPD and typically developing children, and then in a follow-up study looked at comparing children with SPD to children with autism. So when she looked at SPD compared to typicals, she found differences in the posterior region of the brain, particularly in the parietal occipital tracts that are involved in auditory, visual, and tactile integration. A deficit in sensory integrative functioning, now having a biological basis that we can attach to it. And then really what's very important is is this the same or different than other clinical disorders? And I know she's looking at a wide range of different categories of children, but the first group was children with autism. And not surprisingly, there were similar problems, pathology in the white matter in those same sensory regions in children with autism. However, the connectivity seemed to be lower in the children with SPD compared to the children with autism. And then on top of that, she found that there was a deficit in the social emotional processing pathways in children with autism that was not present in the children with SPD. So this is a really huge breakthrough in terms of our findings. Additional biological evidence comes from Dr. Patty Davies' work and her colleagues at Colorado State University. And they're using something called a paired click paradigm, during which the person hears 2 clicks within 50 milliseconds of one another. And so when we experience something called normal sensory gating, the person will actually respond less to the second click because it's perceived as being redundant. Okay? So not surprisingly, in her studies, she found that the children with SPD did not benefit from that first click, so that they, in fact, responded more equally to both clicks, as opposed to what normally happens is that you have a reduction in that click, and that's present in children as well as adults. And lastly, in our lab, we've looked at EEG data using what's called a multisensory integration paradigm, where we deliver an auditory stimulus, which is also a click, a somatosensory stimulus, which is vibration to the median nerve, and then the 2 simultaneously. And so what we've found, just to orient you, I realize your pictures aren't in color, but you can fill it in. The black wave is the response to the click. The red wave is the response to the vibratory stimulus. And multisensory integration is reflected by the green wave. So what we found was that typically developing children have a much higher green wave, larger than the sum of the 2 individual sensory stimuli. That is the definition, and that is what reflects multisensory integration. But of course, if you look at another picture, and you don't have to be a neuroscientist to see the differences here, that was not the case with SPD. And as you can see, the waveforms are much more disorganized. They're not in sync, as you see, lining up in the typically developing picture. And so evidencing that there is not the same type of multisensory integration going on. So now let's talk for a minute about some of the behavioral evidence, which comes out of the work of Dr. Hill Goldsmith and his colleagues at the University of Wisconsin in Madison, and Dr. Alice Carter and her colleagues at the University of Massachusetts. Dr. Goldsmith has been following twin pairs for many, many years, and in one of his studies, he had a group of children who had sensory overresponsivity symptoms. And so if you look at the first column under yes, there are a total of 201 children who had sensory symptoms. Within that group, however, there were 117 of those children who did not qualify for another DSM diagnosis. So that's 58% of that sample had no other diagnosis but these sensory symptoms. And in a similar study, where Dr. Carter has been following babies that were born in the New Haven area from infancy to school age, a subset of the group that she's been studying had also overresponsivity symptoms. And in her sample, 75% did not meet criteria for another DSM diagnosis. And in fact, in her studies, she found those children had greater functional impairments, they had lower adaptive behavior scores, and they had more clinically significant internalizing and externalizing behaviors. And not surprisingly, those symptoms were associated with greater family impairment due to their children's emotional and behavioral issues, And in fact, those impairments were greater than children who even had other mental health diagnoses. Additionally, those symptoms seem to persist over time. They don't just go away, so that those who were identified as infants were more likely to show symptoms at school age, and those who were identified at school age were more likely to be the infants who had been identified in a younger age. So, moving right along, how do we know if a child has SPD? So I'm going to turn this question over to Karin, who's going to discuss our assessment procedures following the STAR model.
Thank you. Okay. Can you hear me well enough? Okay. So I will be talking about assessment in the STAR model, and let's get started. So one thought that I want to leave you with today is that assessment can and should be the window into a client's world. How it is done and what is discovered can and should set the stage for successful intervention. So what does it mean, a paradigm shift mean, when we think about assessment? I think firstly we use our clinical reasoning. We ponder, we reason, we reflect, and we spend quite a bit of time in our heads thinking about a client. And I think this is clearly depicted in the first picture on the slide. Also, how we do our assessment depends on many factors, and we all have different ways of doing it. Again, the second picture on the slide, your way is probably not better than my way, but I think as long as we have a main goal in mind, and that is to really get really good information about a client so that we can do successful intervention. So today's presentation on assessment in SPD is to share with you the how and the what of what assessment is in the context of the STAR model. So looking at the content of this presentation, we'll look at the STAR philosophy on assessment. We will look at the how of assessment, looking at assessment of SPD. We'll briefly look at the sensory processing 3 dimensions, assessment and inventory. And then we'll look at tests that are not typically seen as tests of sensory processing. We'll look at the what. So what do we do with that information that we get from tests, including the interpretation and obviously communicating the results to parents. And then how do we proceed from assessment to treatment planning, and also formulate parent-centered goals. So the STAR philosophy on assessment. What makes the STAR approach to assessment different? The STAR model on assessment of SPD aligns with the STAR model, and the STAR model is an intensive model. It's process-based, and also encompassed in this the STAR model is a problem-solving approach, as well as we will also look at assessment as treatment. Sometimes we do use assessment as treatment. Okay, so let's look at the STAR intensive model. Intensive in the STAR models refer to an accelerated program with a high frequency of intervention sessions. And the implication for an accelerated program, especially for assessments, are a quick turnaround time from doing the assessment to the parent feedback. That typically sometimes happens within 1 day. And to do that, we require to have master clinicians who can interpret test results quickly. Clinicians who have a solid understanding of sensory processing disorder and is able to link the subtypes to the test data that they get from their assessment. These master clinicians should have excellent clinical reasoning to connect the dots for the families. Should be able to relate the parents' functional concerns to the test results and the SPD subtypes. Okay. Further to the process, the assessment process at STAR is fluid, and it consists of a flow of activities. And those activities can be, include tests or test observations. It also consists of a flow of interactions, whether the interactions are verbal or nonverbal, social or procedural. And then also it includes or consists out of experiences. And also encompassed in this process is the ability to use our clinical reasoning. And clinical reasoning is used during all aspects of our assessment process. Also, we use problem solving, and we use it during the flow of activities. So how do we see more of what we need to see? How do we make it happen? Also, questioning. We ask questions such as why and what and how during our assessment activities, interactions and experiences. And then we also focus on relationships. What is that relationship like between the clinician and the client? Between the client and the caregiver? Between the clinician and the caregiver? All of those components that we keep in consideration. Further to the process starts with us during the first contact in the waiting room, and we try and observe to see how this client is able to attend. Is this client able to relate? Is this kid able to engage with a caregiver, with a clinician, with people around them? Also, our process includes standardized testing, structured and unstructured observations in the clinic. And we also look at everyday activities as part of our assessment. Does this child need support to do transitions from one room to the other? Look at self-care. Is this child able to take off and put on socks and shoes? Are they able to ask to use the bathroom? Are they able to communicate if they need water, if they're thirsty? What is their self-management like? Can they control their anxiety? What is their participation like? And are their interactions appropriate? Looking at the problem-solving approach of the STAR, using that in the STAR context, how do we make the pieces of the puzzle fit? So some of the questions that we may ask as part of a problem-solving approach is, how does SPD impact the client's engagement? How does it impact their participation and their function? Does it impact their regulation? What other further questions do we need to ask? Questions such as, how does SPD interact with other comorbid diagnoses? Should we consider other frames of reference when we interpret our test results, such as should we look or use a different lens when we look at this child or client? Should we use just an SPD lens? Should we also look at this child through a developmental lens or a neurodevelopmental lens? Okay. So let's also look at assessment as treatment. When we cannot formally assess, can we substitute assessment with treatment as a means to assess? And what strategies, principles, approaches did we use to support the child to observe optimal capacities? So, can we attune to the client's needs? I can attune to feeling nervous, matching up with that lion in the picture. So what did we do to support the client's level of play? What did we do to support the client's level of regulation during that assessment or treatment session? The client's engagement. Did we provide scaffolding to sustain participation? Okay, so let's look at a video of assessment as treatment. This is a video of Andrew with a social anxiety disorder who could not be formally assessed. The therapist, one of our very skilled and experienced therapists at STAR, substituted assessment with treatment to gather information. So observe his challenges with ideas, motor planning, sensory modulation and regulation. Also observe how the clinician, her name is Mim, acts as his co-regulator through play and understanding his underlying sensory processing challenges, which became very evident throughout his assessment as treatment. And then we will look at the questions we could, to help us understand what are the causes of Andrew's challenges. Okay. So this is Andrew and Mim.
Got it. Oh, my jump. Jump and catch. Okay. That might be fun. Over here, over here. Get in. Oh, yeah. Uh-huh. Oh. Me. Whoa! Oh, phew. Oh.
Okay. So what are the questions we should ask to, to inform our clinical reasoning and when we do assessment as treatment? So what did Mim do to support him in the areas necessary? If we look at regulation and emotion regulation, she attuned to his anxiety. She picked up on that. And she met him. Arousal, she attuned to his sensory over-responsiveness and his praxis challenges. Engagement, what did she do there to support that? His engagement was limited until she played with him at his level. Very simple play in the ball pit. And she connected through affect and sensory toned down interactions. How did she relate with him? She allowed him to return to the ball pit every time he needed co-regulation. He would go back, they would play his simple game, he'd get regulated and be ready to move on to the next game or idea. She supported his challenges with ideas and motor planning by reading his intent and slowly building him to the point where he could swing on that swing. If you think about the first time he went to the swing, tried to get on it, didn't know what to do on it. It moved, it was unstable, immediately disengaged and moved away. And look at how he was swinging at the end of that session. Joyful and having fun. Okay, so let's move on. What does a typical assessment of SPD look like at the STAR Center? It's a 2-hour assessment. We use standardized tests. We use structured and unstructured observations in the clinic. And we also use parent report measures. We then interpret the test results and we write it up. And then we do parent feedback. And then we move towards the treatment planning, setting parent-centered goals using the goal attainment scales. Specific tests of sensory processing used at the STAR Center, the Miller Assessment for Preschoolers, or the MAP, sensory integration and praxis tests, and then the sensory processing 3 dimensions assessment. So Lucy mentioned that in her introduction, and I will briefly tell you a little bit more about that. So it was previously known as the sensory processing scales. It evaluates sensory processing abilities in children 4 to 12 years. Lucy also mentioned maybe 4 to 16 years. It measures constructs parallel to the SPD taxonomy or subtypes. And those, so that the subtypes that the taxonomy corresponding with, or the constructs corresponding with the 6 SPD subtypes. It measures modulation, sensory over-responsiveness, and sensory craving in each sensory domain. It measures sensory based motor abilities, postural control and praxis, sensory discrimination, and then also complex skills. So I will share with you 2 video clips of 2 tests of this new wonderful assessment that's in development. The first one is called the GOO game, and it measures adverse or disappropriate responses to tactile input.
All right, can you find this animal now?
It blends in good.
It blends in good. Using those eyes
But
to
I
look
see
for
it.
them? Oh, good.
Yeah, I see this big.
Good, you're getting it out.
So he has to find a little plastic animal hidden in the goo. And look
Can
at
I find that goo when you're done?
the nonverbal reactions.
Thank you.
or
How do you like
language.
touching it?
I don't touch it.
You don't like touching it?
Not much.
Okay, well, we will put that away.
Full clean in his hands. Okay. So there you could see he had the language to tell that he didn't like it, but also you could see that in the nonverbal and the gestural language as well. Okay, and the next one is about, it's called the Superman test, and it looks at posture and praxis. We will not look at the full video clip. You will see this child's challenges with posture and praxis halfway through the clip. So we'll just take a brief look at that.
Okay, no, leave your body straight. You're just bending your elbows. You're pushing with your arms. Bend. Bend your elbows. Can you bend your elbows? Like that. And bend the other one. And then push. 1, 2. Keep your back straight. Okay, ready, go. 1,
So
2. Okay, watch me again. Ready?
okay, we'll stop right there. So that was evident without having to go into too much analysis. Okay, so let's quickly look at the parent report measures we use at the STAR Center. We use the ABAS, or the Adaptive Behavior Assessment, the Behavior Assessment for Children, or the BASC, the Sensory Processing Measure, the Short Sensory Profile, the Sensory Profile, Adolescent and Adult Sensory Profile, and then also the Sensory Processing 3 Dimensions Inventory. Okay. These are the ones that are most frequently used at the STAR Center, and all the PRMs, parent report measures, are selected very specific to the client to provide the best possible information. And PRMs supplement our standardized test data and observations, whether it's structured or unstructured. So what are the tests that are not typically seen as tests of sensory processing? So we'll quickly look at the tests. We'll watch a video of the Miller function and participation scales. And then we will look at how to use these tests. In other words, the interpretation process, we will look at the bottom-up approach. We'll look at some of the process points, and we'll look at a process flowchart. So one of the tests that we use is the Miller function and participation scales, or the MFUN, the goal-oriented assessment of life skills, or the GOAL, and then the Brnick-Ozoretsky test of motor proficiency, or the BOT.
I just have a quick question. If you're using the SIPET as one of your tools, how do you get all of that done in 2 hours?
I'll quickly answer that, but we will have time for questions and answers. If we do use the sensory integration and praxis test, how do we get all of it done in 2 hours? So I do it. I do not administer the full test because, it was on one of the slides. Our intake procedures are pretty comprehensive. So I typically determine ahead of time which tests I think I should use to inform myself. But any other questions, we will have time before the break and then later after to answer questions.
Thank you.
Okay, you're welcome. So let's look at a video of the MFUN. So this is a video of Ryder, who is 4 years old. I want you to look at his performance of the MFUN tests, his behavior and his attention. You will also see a video clip of him during unstructured observations later in this presentation. See if your hypotheses based on these observations match up with what you see during the unstructured observations later. Oops, excuse me. Let's just get him started here. So this is Vin and Ryder.
Can you help him? Good job. Same thing right here. All right, here comes this person. I cannot wait. What's he gonna look like? Ooh. What did you make? Oh my goodness. We're gonna use 2 hands and roll it like this. Good job, keep trying. And put them in the piggy bank. Oh, only one hand. Oh, it's getting full. Oh, he's still hungry. You fold yours like mine. So turn him over and fold it right down the middle. You gotta push it hard. Oh, uh-oh. Watch me. All right, can you pour us both a drink? Nice. Well, thank you, sir. Oh, good.
You have to do that a lot at school.
No,
come out.
Whoa! Are you okay?
I'm not sure I can do that.
Well, you did a great job. Ready? Woo! Good try. Okay, this time. And see if you can throw it to me. Ready? Oh, you can do it. Ready? Oh! Thank you. That's good. Okay, watch my feet now. We're gonna do a different one. Oh man, you look like you need a really big hug. Can mommy give you a big hug?
Okay, that's Ryder. Okay, so how do we use these tests using a bottom-up approach? How can we use the MFUN subtest scores and observation to link it to SPD subtypes? What is needed to do this? Well, we need to have a solid sensory processing knowledge and understanding of the function of the sensory systems. We have to understand what each subtest measures and the neurological foundations of each subtest. And we should have excellent insight and clinical reasoning to link observations and data to SPD subtypes and parent concerns. So on the slide, you see again an example of the SPD taxonomy. Dr. Muller referred to it previously as well. So if we want to look at our interpretation process or clinical reasoning process, this is an example of a tool that you can use. I compiled a table. On the left hand of the table, the columns are listed the SPD subtypes, and at the top of the table I listed the MFUN subtests and neurological foundations. And then I used the color keys to indicate where I think this child fits, using the test data and observations to inform my clinical reasoning and really to fine-tune what I think fine-tune my hypotheses. So just an example, for instance, if you look at the sensory discrimination part, tactile, I put there mazes, and I could also put there pennies, but mazes in the sense that this child had to transfer the marker from his right hand to his left hand and back to his right hand to adjust it, to hold it, to be able to draw. And that is an in-hand manipulation problem. So in that sense, my hypothesis is that he probably has a tactile discrimination, underlying tactile discrimination issue. I'm not going to go through this whole model in detail, but this is just an example of how you can, it's a tool for clinical reasoning and how you can narrow down and put all your test data and information together to give you a clear idea of, and you can do it with any test. Okay, so I quickly want to talk about using test data versus watching and observing performance of test items. So at the STAR Center, it's a culture to video our assessments. And what the benefits of doing that is it provides qualitative information to supplement our quantitative data. It enables us to do refined clinical reasoning to tease out the finer nuances of areas of challenge. And by doing videotaping and watching videos of assessment later, we are able to ask questions such as, how did the child perform this test item or activity? And which sensory processing function do we think is underlying this difficulty? Is it a sensory discrimination issue versus a sensory modulation challenge? What sensory systems are involved? And why? Do we think it's a praxis or a postural disorder? Is it due to over-responsiveness or under-responsiveness or craving? What do we think about the child's social emotional pieces and behaviors that we observed during that assessment? So I want to encourage you all, if at all able, videotape your assessments and review it as you interpret your test results. So here's another example of a bottom-up clinical reasoning tool. It's a flowchart of how we also supplement our reasoning and our interpretation. Starting at the top, you can list a test item or a subtest, and then try and delineate, is it a discrimination issue or is it a modulation issue? And then identify which sensory system is involved, or which sensory systems. And whether you think it's a dyspraxia, whether it's a postural disorder, and then fine-tune your hypotheses, whether it's a somatodyspraxia, bilateral integration and sequencing disorder with a postural component, or do you think it's, it's mostly a modulation and regulation issue? And what do you think it is, SOR, SUR, and how does it impact the child's behaviors and ability to interact and be successful? So let's look at a top-down approach, and that is our unstructured observations in the clinic. So we looked already at assessment as treatment, but we always supplement our standardized testing with unstructured and structured observations in the clinic. And structured observations, I'm sure everybody is familiar with. We use clinical observations in our clinic, but unstructured observations also examine and assess and look at aspects such as play. What is the child's level of play? What is this child's behavior during the assessment? Look at their praxis abilities. Do they have ideas? Can they put those ideas into action? So can they motor plan? And how are they able to execute those motor plans? We look at sensory modulation, playing with soap foam, playing with dry tactile media. You saw Andrew with the lights and the sound machine, or the Makoto, how he responded to the sound of that machine. A really nice indication of sensory auditory over responsiveness. What is the child's engagement and attention like, and what is their arousal like? So let's look at Ryder during unstructured observations. You saw him during participation in the M-Fun. And think about if these observations refute or confirm your hypotheses based on his performance of the M-Fun tests. And think about what other structured observations you need to do to confirm or narrow down your hypotheses. And are there more questions generated through these unstructured observations that you need to answer? So let's look at Ryder.
Oh man, what's going on in there? Do you need some help? Muscles. Good job. Come. Are you gonna sit on this thing? Ooh. Thank you. Huh. Wow.
Stop this way.
Stop this way. Oh my goodness. Oh man. Okay, okay, hold on with your hands.
Hold on to him.
Here he goes. Oh, not ready?
No.
Well, how do you get back down?
Come here, grab on. Hold on to the handles, bud.
You gotta hold on to the black handles and Daddy's gonna hold you. Here he goes. Wow.
Okay, let go.
Okay, so keeping in mind what I asked you, I mean, it's evident postural controlled praxis, some modulation issues, but and underlying that, a lot of sensory discrimination challenges. So how do we move from assessment to treatment? How do we link our assessment findings to the presenting problems, those parent concerns that the parent come to STAR with initially? So we use assessment data, we use our parent concerns, we look at the observations in the clinic, whether it's structured or unstructured, and we formulate a hypothesis based on all of that information. And we link it to the SPD subtypes, function, play, engagement, and the ability to relate. And then we formulate impact statements, and I'll show you an example of an impact statement right now after this. And then obviously we formulate our intervention goals, and we also look at what other questions were generated during this assessment and that still needs further answering, and we should look at during our intervention. So at the STAR Center, we write impact statements trying to relate the parent concerns to our assessment findings. So impact of X would be the SPD problem identified, on Y the functional parent concerns. So in this case, impact of challenges in postural control and on coordination and being accident prone. Okay, so I'm not going to read through that. It's just to give you an idea of how we do it, because we want to put it in language that parents can understand and that they can go home and talk to the teacher or their OT back at home and relate to. It must make sense. It doesn't help. It's a lot of jargon and language that they don't understand and barely can remember half of it. So how do we empower our parents? We use material to educate without overwhelming parents. We relate information to, related to their child in a language that they understand. So I will briefly review the handouts that we share with the parents during our feedback and then circle back to summarize how we integrate the assessment information with and communicate it in a language that parents understand. So one of the education pieces that we use is the bell curve. And this is used to help parents understand their child's test results in the context of the bell curve. So if whatever test we use, we will obviously relate the test findings in context of the bell curve. We also use the arousal regulation model. And here we help parents understand the regulation and arousal model and understand their child's behavior, such as meltdowns, poor attention, difficulty with learning, in the context of this arousal regulation model. And then also the sensory pyramid. And Dr. Miller will talk about that in more detail in her presentation, so I'm not going to go in detail into that right now. Again, the sensory pyramid is used to help the parent understand all the factors in play for their child with SPD and understanding the processes that support successful and joyful living and what needs to be done to get to that point. So also looking at how we empower our parents, we want to relate our assessment findings to our parent concerns. So we will identify the primary SPD subtypes of the child. We will relate those subtypes to the presenting problems through our impact statements. We will reframe the child's functional, social, and participation challenges in the context of SPD. We will summarize and emphasize the child's strengths that will support their progress in therapy. It's really important to tell parents what their child is doing well and what their child can do. As opposed to just telling them what the child cannot do. And then we will make recommendations. So here's a short video of riders' parent feedback. And I want you to focus on the fact that there should be a balance between educating parents and listening to parents' concerns and answering their questions, as opposed to just talking and talking and talking. Parents come to you. They have concerns, they want somebody to understand, empathize, put it in context for them, and then give them hope, knowing that there's help and that you are going to help them. So let's look at this video.
We weren't as aware of all the SPD stuff last summer. Okay. The speech was so far behind that it was on a different pediatrician. That pediatrician said immediately, she's like, he's textbook, like across the board. Yeah. She said on top of apraxia, he definitely has sensory disorders. How? He knew exactly what you wanted. That's very difficult for him.
That manipulation
That sort of manipulation with his fingertips like that, I would say is right at the top of extremely difficult for him. We try to work with, even folding the paper over like he normally would, just taking it and just, there you go, we're done with that one, move on. In reading, he kind of falls more into that global apraxia sort of.
So we call that dyspraxia.
Okay.
So the dyspraxia is like with the body movements and the motor planning through that.
So is it dyspraxia and apraxia?
Okay.
They're separate, but they're very commonly seen together.
Okay.
Very common.
And so is this like dyspraxia, apraxia, and sensory processing?
No, so that's kind of how we're a little different.
Okay.
We kind of use this nosology. So there's the sensory modulation disorders.
Okay.
So these are the ones that most people are very familiar with, the over-responsive, under-responsive.
He's the under-responsive for sure.
Yeah, I think he has some qualities of under-responsivity. There's a lot of the under-responsive things that you're seeing, or the craving behaviors, I think are due to a discrimination dysfunction. So his ability to interpret it would make this our number one, the sensory-based motor disorders. So that's postural disorder and dyspraxia we put under there. So before we can do any of these higher level skills, the oral, fine, gross motor, that's really kind of very low. We have to be able to discriminate and modulate all these. Yeah.
We don't even leave him with our parents.
Right.
The only person he gets left with is our daughter. And she bears a very large brunt, unfortunately. And it really makes me worry, what happens when he's older and he wants to go to a friend's house?
Right.
Do you send that over to a friend's house? I don't expect somebody else's parent, to know what to do with that when I don't even know what to do with it.
Right.
It's Victor, can he control this right now, or are we asking too much?
Absolutely.
And that's the stuff, I just don't know where that line is.
Right. It's hard to know.
Okay, so this is just a short example of trying to keep the balance in terms of give the parents the opportunity, listen, understand what they're going through, and then reframe it in the context of SPD, and then also support and hope. So how do we move on to intervention planning? How do we do it? We use goal attainment scaling. And why do we do it at the STAR Center? The STAR Center is family-centered in our approach. It's an intensive model, and because of that, we would like to demonstrate small increments of change over a short period of time. The goal attainment scales measures a wide range of skills and behaviors. It's really meaningful to parents, and there is always increased satisfaction when change is measured. So that's really important to keep in mind. How do we engage the parents in treatment planning, or the process of doing that? Parents identify some desired outcomes of treatment. What do they want to see change? Whether it's a meltdown, whether it's attention, whether it's the increased engagement or social intent. Then we work with the parents and we help them identify 4 to 5 concrete measurable outcomes. It's a process, helping them understand and talking through things and narrowing down those outcomes. Then we talk about the current level of performance. How is the child currently doing that? If they have meltdowns, is it happening 10 times a day? Is it happening 5 times a day? What is the intensity? What is the frequency? And then therapists in collaboration with the parent narrow down those goals to specific outcomes. So I want my child to have 1 meltdown a day or 2. Obviously something that's realistic, and what the therapist then does, she makes an educated guess of what is realistic to achieve in a treatment duration. So unfortunately, we don't have time to go into too much detail in terms of the goal attainment scaling, but I think Dr. Miller also touches on that in her presentation. And so this wraps up my part of assessment in SPD. And thank you very much for the opportunity to present to you guys. And now Dr. Miller will continue with her presentation on the STAR model. Okay, now are you going to do? Okay, perfect, thank you. Are you going to just use Sarah's? No, I'm going to do my own computer.
So would you like to stand up and take a stretch break and be proactive in stretching your muscles? Diana, do you have that song available? That little song? You want to do a little activity with us so people don't... Where is my computer? Oh. You know, I think you have to do a little OT, and you can't just talk about OT. it here. Hang on a second. I need to hook up the blue thing.
Okay.
The blue thing, you know, the blue thing?
Yes, that's enough for I'll get it.
Here, this is it. And it goes right here. Do you need to see your thing?
It would help them
Okay.
to
But we want
see
to help them.
possible. You want to help them?
I do.
That just sounds just like you, Lucy.
Oh my gosh, no, that's not the right one. Is it not here?
Keep going.
All right. So
Over here on this side.
for those that
Nope.
that are not familiar, this is from the
not this
Songs
one.
for
Yes, yes, it's
Tots music CD,
It's on the other side.
and it's a song that
Oh, there we go.
typical kids love. And since you're all typical, are we? I don't know. But anyway, it's kind of focuses on the whole motor planning, sensory-based motor disorders, as they say. And you basically follow along. It's a little challenging if you have some of those sensory motor disorders, but it's a lot of fun. So I'm just trying to find it here, of course. All right,
What did you say the name of it was?
it's from the Songs for Tots music CD, and it's called Here's My Nose. So, can I plug?
No, we're not
Sound?
detecting it.
Okay.
You can plug it possibly in here. What is it, an
Oh, no, I was gonna plug to sound. Do you have a sound thing?
do you have that phone?
Yeah. Thank you. Technology, how great, huh? When it works. Because it's not on. Okay, everybody, close your ears. Voila.
I'm not picking up your stick.
Oh, you're not picking up my stick? Huh. Okay. So I guess, sorry.
Go ahead.
Do you,
Go ahead. Do what you're gonna do.
okay?
But we aren't gonna have the picture.
Okay, we're not gonna have.
Here's my